All right. Well, welcome back to those who joined us this morning, and welcome to those who are just coming for the first time to the 7th Annual Women's Heart Symposium. We're glad that everybody can join us and happy to have you here. Just a couple of remarks. Those that everybody that signed up and comes into the Zoom will get a 7th Annual Women's Heart t-shirt, which people still ask about over the years, and a flash drive with the PowerPoints and the slides and some references that are on there. So everybody will get that. Please try to remember to use the Q&A button at the bottom of the screen if you have a question, and we'll pass that on to the speakers in the question and answer session. So I'll be monitoring that with Brian and Allison. And we want to keep this symposium going forever. So we hope to be able to keep providing it free of charge for everybody. We've done that up until we've done that from ever. It's been in person until this year. We're doing it by Zoom the first time, so it's kind of nice. But anyway, welcome and join us. We have Matt Baker, Dr. Matt Baker, who joined UNC. I guess Matt came here in 2012, and is that right, Matt? Or 2000?
That's when I started fellowship. Yep.
Yeah, and he stayed on as a permanent faculty member, and we're very happy to have him. And then Dr. Casey Gazda, who came by way of Illinois and Iowa, and was our chief fellow for this year, and is staying on as our imaging fellow for next year. So welcome. And I'll just ask you guys how you've been this year. This has been a difficult year for difficult and good in some ways for a lot of us. So I'll start with you, Matt.
No, thanks, Dr. Miller, and thanks for having me here. You're right; it has been a very interesting year, to say the least. And I'm doing okay. Our family's doing okay. As you know, we've had a new addition to our family early last year, and it's been interesting. She's only met a handful of people in person so far, so we're looking forward to introducing her to some more people in person over the next year.
And she has two little brothers, right?
She has two older brothers who, yep, they've been great. They're really looking after her, and as far as work goes, it's been some changes there, but it's been nice to incorporate these remote visits and remote conferences. And I think this has been I don't want to call it a silver lining necessarily, but it's been nice to have this tool incorporated into our work, and looking forward to doing more like this.
It is. It allows us to do this meeting. That's an important part. And Casey?
Yeah.
No comments about Wednesday afternoon clinic.
No, I love Wednesday afternoon clinic. But yeah, I think this past year as a fellow in the pandemic, and particularly a chief fellow, has presented a lot of unique issues that I never anticipated I would be dealing with as a chief fellow. But I think it's provided us all an opportunity to come together, work together, and overcome a lot. And so that's been really rewarding. But in our personal life, my husband and I are expecting our first child now, a little boy, who will be due in July. So that's really exciting for us. And I feel really thankful that although I haven't been able to see my family for most of my pregnancy, for my grandparents, this is our first grandchild in the family. But hopefully with the vaccine, everyone will be able to meet baby this fall. So
that's pretty really exciting. That is pretty exciting. And she's handling it very well. She just came off nights, which is a stressor, and she looks wonderful. All right. Well, Casey, you want to go ahead and get started?
Yeah.
Let
me share my slides.
Casey Gazda.
All right. You should all be able to see me and see my slides. Is that right? All right.
Yes, we can see you.
So I am very excited to be here talking to you all about advanced cardiovascular imaging today. The goals for this talk are to give you a brief kind of overview, introduction to advanced cardiovascular imaging. We have a short period of time to go over a very big topic, but hopefully this is a little teaser for you. I'll do a brief overview of some of the technologies we use in advanced imaging, and to give you a couple of examples of why this is important in cardiology and particularly important in women's heart disease. So what is advanced cardiovascular imaging? Well, when we use this term, we're typically talking about cardiac CT, cardiac MRI, or advanced echocardiography. And we're doing specialized techniques and protocols using these imaging modalities to either look at a structure within the heart or that structure's function within the heart. But we also sometimes use them if we want to make a disease diagnosis or monitor a patient's response to treatment. So if we start with cardiac CT, CT stands for computed tomography, or you may have heard it called CAT scan before. This is a type of imaging where we put the patient on a table, they slide into this round donut-shaped machine that's got an X-ray source in there spinning around very quickly, taking 360 degrees of X-ray images and compiling it into these slices that you can see. And we put all those slices together like the loaf of bread, and we are able to see the structures within a patient's body in cross-section. Now, imaging the heart is a little bit more difficult, and so that has required a lot of advances in technology because the heart is the only structure in the body that's constantly moving, and it's moving very quickly. So if you imagine trying to take a picture of a bumblebee who's flying, if you don't have a really high shutter speed, his wings are just going to look like a blur. And that's what many of the structures in the heart would look like if we didn't have the ability to, as you can see down here, turn on the imaging scanner at the brief fraction of a second when we want to between heartbeats when the heart is at its stillest motion. So technology for cardiac CT has come a long way. And one of the most important reasons we use this is for coronary artery disease assessment. And as you can see, even back in the 90s when CAT scan had been around for 10 or 20 years, this is what it was like to take pictures of the coronary arteries. They were very blurry. And even though we knew there was something there, we couldn't really make any assessment of that. But our current technology today allows us to take these really beautiful, crisp, clear pictures of the coronary arteries with a CAT scan. And so this is a picture here of all three of the coronary arteries and the types of images that we can get. We can do really wonderful 3D reconstructive modeling for not just the coronary arteries, but structures of the heart. And one of the advantages to doing a cardiac CT is that compared to the standard of care, which is a coronary angiogram or heart cath, or a stress test, you can get really detailed information about the vessel itself, how much calcium there is, how much plaque or cholesterol buildup outside the artery there is, and a lot of characteristics that you might not get with other types of coronary imaging. This is the scanner that we have here at UNC. It's called a Siemens Somatom Force. As you can see, it's got actually two X-ray sources that spin around the patient. And this is really great because this newest technology allows us to scan the entire heart and get pictures that look like this in a fraction of a couple of seconds. Some patients who qualify can actually be a part of the FLASH protocol where we can scan an entire heart and all the coronary arteries in under a second in a single heartbeat, which is really, really remarkable compared to those pictures that we saw from back in the 90s. So if we skip ahead to echocardiography, which is ultrasound imaging of the heart, this uses sound waves, so no radiation to the patient, which is important for women to know because we have breasts in our chest. And so we want to be cautious in thinking about how much radiation we're exposing ourselves to in our chest area. But we use an ultrasound probe, as shown here on the left, that produces sound waves. We transmit that through the tissue, and we listen for those sound waves to echo back to us. And the computer, via magic, turns that into pictures we can see. When we're talking about advanced echocardiography, we're typically talking about doing a couple of different things. Either we're using specialized techniques with our ultrasound handheld probe to do three-dimensional imaging or something we call strain imaging to get really great pictures of structures within the heart in real time or assess how the heart is functioning. Or we're talking about doing transesophageal echo or TEE, where we put an ultrasound probe through the mouth and through the food pipe or the esophagus, where we can get up really close to the heart and take beautiful, crisp, clean pictures of the heart. And we often do TEE during a lot of our interventional structural cases. You guys, if you've joined this symposium before, you've probably heard of TAVR and MitraClip and some of the procedures that we're doing in our cath lab now, being able to spare patients open heart surgery. Many of those procedures require real-time imaging guidance for placement of those devices. And so this is an example of one of the devices we place, the MitraClip. Here on the left, you can see that there is an image that we're taking during the procedure. This is the mitral valve, and it's got two leaflets that come together. And all of this color right here represents blood flowing backwards in the wrong direction across that valve. So we place this clip there to kind of cinch those valve leaflets together. And so we provide transesophageal echo real-time imaging to monitor where this clip is being placed, help the interventional doctors make sure they're grasping the leaflets appropriately. And then we're able to take these really wonderful real-time three-dimensional pictures of what that valve looks like and give them an idea of what it would be like if they did have the patient's chest open looking at the heart, whereas we're doing this all based on catheters going through a blood vessel and imaging guidance. This is just another example of pictures that we can take. This is when we did a mitral valve replacement over a catheter. Again, not opening the patient's chest, strictly doing this with a catheter in the blood vessel, images on the screen. We provide this real-time imaging. This patient's already had a valve replacement before, but as you can see, the leaflets are not moving very well. So we're able to provide what the valve looks like before, help the doctors who are doing the procedure put the new valve in the right position. And then afterwards, we get this really beautiful picture of the new valve sitting inside the old valve. And we can see that those leaflets now open up really nicely. And last but not least is cardiac MRI, or magnetic resonance imaging. Now, this is a pretty complicated type of imaging modality. The scanner looks similar to a CT scanner in that there is a kind of donut-shaped machine that the patient lies on a table and moves through. This is an example of what we have here at the UNC. It's a Siemens Avanto 1.5 Tesla machine. Similar to echocardiography, MRI does not use any X-ray radiation. It actually uses magnetic fields and radio waves to image the tissue. Now, there's a lot we can do with MRI. I could spend an entire hour just going over the brief imaging modalities and different types of protocols that we can do with MRI, but this is a collage of some of the examples of images that we can take depending on what we want to look at within the heart. There's various mapping protocols that we can do. We can assess how the blood flows through the heart with really sophisticated mathematical and computer programs. And we're able to take real-time images of the heart here too. These would be beating, and you could see the heart beating in real time as well. One of the more common reasons that we get asked to do a cardiac MRI would be to diagnose a disease called sarcoidosis. Sarcoidosis is an inflammatory disease that kind of typically affects the whole body, but predominantly affects the lungs and can affect the heart. And it is more common in women, much more common in women actually, than it is in men. And if it does affect the heart, as you can imagine, inflammation in the heart can cause quite a few problems. And so we do cardiac MRI to take pictures of the heart muscle. You can see here that this heart muscle is healthy. It's supposed to show up as a black tissue within the MRI. But patients who have sarcoidosis have this white kind of cottage cheesy appearance to certain parts of their heart muscle tissue. And so that helps us make a diagnosis of a pretty specific disease of sarcoidosis. And then we can use MRI in the future to re-image the heart once that patient's been on treatment and see how much of that inflammation is left over or if it's all completely resolved. So again, that was a very brief, quick run through of some of the imaging modalities we have. I thank you all for being here and look forward to answering any questions you have at the end.
Thanks, Casey. That was great. And we will allow questions. Well, we'll have a lot of time for questions at the end. So I'm going to, without ado, move right on into Matt. You there, Matt?
Okay.
Hey.
Thanks, Dr. Miller. All right. So I'm going to talk briefly here about atrial fibrillation. Again, my name is Matt Baker. I'm a cardiac electrophysiologist here, meaning I deal with heart rhythms and heart rhythm disorders. One of the more common ones is atrial fibrillation. So we'll do a quick overview here. To start, what is atrial fibrillation? So as you may know, the heart has 4 chambers, 2 top chambers or atria, and 2 bottom chambers or ventricles. And normally the heart beats top and then bottom, top and then bottom because of an electrical signal telling it when to beat. That starts in the top right chamber. The heart has a natural pacemaker that generates that signal. It tells the top chambers to squeeze, and then the signal travels down some natural wiring and tells the bottom chambers to squeeze. That's the normal order of things. For a number of different reasons, the top chambers of the heart can stretch and thicken, and over time, places that didn't normally make electrical signals can start to get excitable or irritable, and they can start making their own electrical signals. And if you get enough of that stretching, thickening, and enough of those extra electrical signals, then what we can get is this thing called atrial fibrillation, which is a random, chaotic electrical activity through the upper chambers of the heart. And instead of squeezing all together, they start wiggling or fibrillating. So that's atrial fibrillation. And what happens is some of those electrical signals from the top chambers then make it down to the bottom chambers, and they beat in an irregular fashion. Instead of normal top to bottom, it's now wiggling on the top, and the bottom is just sort of trying to keep up. So a little bit of why knowing something more about atrial fibrillation can be important. It's the most common sustained arrhythmia. It can lead to an impaired quality of life. It can be associated with an increased risk of stroke and death. The risk for AF is higher in men, but because in general women live longer and because the incidence of atrial fibrillation increases over time, there are actually more women living with atrial fibrillation than there are men. After one turns about 40, the lifetime risk of having atrial fibrillation is about 1 in 4. So it's a pretty common condition. How does one identify atrial fibrillation? So there are a number of different ways that it can be found. Some people, a lot of people have symptoms that can be attributed to their heart being out of rhythm, of being in atrial fibrillation. Some of those symptoms include palpitations or a sense of the heart pounding or sometimes flopping around in the chest. But the most common symptom really is just generalized fatigue. Sometimes atrial fibrillation can be identified by a device. There are a lot of devices now that look at someone's heart rhythm. Things like home blood pressure cuffs can sometimes identify an irregular rhythm. Very common these days are heart rate monitors or sport watches or Apple watches, things that people are wearing that can look at their rhythm and tell them if they have an irregular rhythm. Then some people have implanted devices like pacemakers that also can identify these things. Now it is important, whether it's symptoms or a device that makes you suspect that you may have atrial fibrillation, it is important because devices in particular sometimes can be fooled. It's important to confirm the diagnosis with a standard electrocardiogram or an ambulatory monitor, such as this patch. It's called a Zio patch, but it's a type of ambulatory monitor that can be placed or recorded in a physician's office. Once atrial fibrillation is identified, what are important things that we do? It's important to identify any risk factors that may be contributing to that condition, and modifying these risk factors can often improve someone's freedom from atrial fibrillation in the future or help with managing it. Something like thyroid disease is important to identify and address. Obesity and sleep apnea, these are conditions that contribute to strain on the heart and atrial fibrillation happening. Blood pressure is important to keep under control. things like heart failure, other valvular or other diseases of the heart, heart artery disease. These are things that can be addressed if they're present. And alcohol is very important to moderate. Another important thing with atrial fibrillation is that people with hearts that can have atrial fibrillation are also at increased risk of developing blood clots in the heart, which can lead to strokes. Someone's overall stroke risk can be calculated by, in addition to having atrial fibrillation, having additional conditions. And depending on how many of these additional conditions one has, it may be indicated to be on a blood thinner. And you'll probably see ads on television or hear about all these blood thinners that are available now. Most of them are equivalent in their effect. There are some reasons to choose one over another, but in general, they work pretty similarly in reducing the chances of stroke. And these days, one new development over the last several years is that there have been reversible agents now available. That was one concern with some of the newer agents, but there are reversal agents now available for all of them if someone's having uncontrolled bleeding. Another thing that you may hear about are other ways, alternatives to blood thinners. So if someone cannot tolerate a blood thinner, if someone's having lots of bleeding issues, but is at increased risk for stroke associated with atrial fibrillation, one way to address that is with a device called a Watchman device. It's a little device, kind of a plug that gets implanted into a part of the left upper chamber of the heart. So it's an invasive procedure in which a catheter is passed via a vein in the leg up through the chambers of the heart into that area of the heart where blood clots commonly form. And this can help reduce the risk of stroke in the long run. Another thing that we think about when we have someone with atrial fibrillation is, should we try and put them back in normal rhythm, or should we try and help them maintain normal rhythm? There are some people who live in atrial fibrillation and do just fine, but reasons to think about restoring and maintaining normal rhythm would be if someone has heart failure, if someone has difficulty controlling their heart rate when they're in atrial fibrillation despite medications, or if someone has symptoms and would feel better in normal rhythm. There are a number of things we can do to help people stay in normal rhythm. There are medications that are available to us, and there are different reasons to choose different medications, but there are a host of medications available to help maintain normal rhythm. Other things that we can do, there are also procedures to try and help people maintain normal rhythm. You may hear the term ablation or cardiac ablation or atrial fibrillation ablation. And what that entails is it's an invasive procedure done via catheters placed via a vein in the leg up into the chambers of the heart and into the upper chambers of the heart. And what our goal is to ablate or quiet down some of the irritable areas that are responsible for getting atrial fibrillation going and keeping atrial fibrillation going. So a procedure like this, this is an example of using radiofrequency or heat ablation, and there's also a technique using freezing or cold ablation. Techniques like this can help reduce the frequency of atrial fibrillation in the long run. There are other invasive techniques to help manage atrial fibrillation. I don't have diagrams of them here, but they would be for more advanced or special cases. But that was a real flyby of atrial fibrillation, and hopefully that was informative. That'll be helpful. Happy to answer any particular questions during the Q&A afterwards.
All right, thank you, Matt. That was very good and informative, and I'm sure there'll be some questions. There's some that had already come in, and we talked about a little bit. How many years do you believe we are from implementing gene therapy for treatment of AFib?
Okay, so that's an interesting and good question. I think I guess the short answer is probably quite a few years. I think the longer answer is that their atrial fibrillation is a complex disease. So, knowing what gene to target is a challenge, but there are some potential targets that have been investigated. There are, I think, even some animal experiments where they've shown some modification of genes that have reduced the incidence of atrial fibrillation. But going from that kind of experiment to having something that can be utilized in humans is a bit of a jump that'll take some time.
Do you think that having atrial fibrillation indicates that you have heart disease?
So I think that atrial fibrillation does indicate that there has been some change to the heart. And I don't know what Paula, you and Casey, how you define heart disease. It's really a spectrum. But atrial fibrillation does indicate to me, in my mind, that there have been changes to the heart. It would put it in a different category from something like, heart failure maybe, or from coronary disease or valvular disease. But yes, again, short answer.
I agree.
Yes,
I think it's
there's been some change.
It's hard to let's see. That heart disease is a giant category under which many things fall. So
a big spectrum too.
Yeah, or arrhythmias, coronary disease, structural heart disease, all those I think would fall under cardiovascular disease, but atrial fibrillation would be one of the arrhythmic changes in our heart. That doesn't necessarily mean that you'll have a heart attack, but it does mean that there's something different in the electrical system. So maybe not the plumbing, but the electrical system. Casey, can you comment a little bit on calcium in your arteries that are seen on CT scans or calcium scoring scans?
Yeah, so coronary calcium scanning has been around for quite some time. And that's typically a test that we do for people who are maybe at risk of coronary disease, but have not had any symptoms or have never had a heart attack. For instance, those with a family history or one or two risk factors, and are just kind of looking to look how their risk looks and do modification of risk factors if they can. Coronary CT scan, the technology we have now is a little bit different. It kind of goes above and beyond just looking at how much calcium is in those arteries. And so, we previously have thought, of course, that the presence of calcium probably indicates that a patient does have some degree of coronary disease. But now we can take really great pictures of the arteries with a very quick CT scan. And we can define how narrow those blockages are. We have technology where we can do what we call fractional flow reserve, and looking at how the blood flow is affected by those blockages. And so really coronary CT now is a step up from what we used to just have as a coronary calcium scan. And the benefit is that it actually has very little radiation. It has about the same radiation for most patients as doing a calcium scan, which is a non-contrasted CT scan of the chest. Whereas if you compare a coronary CT scan to things like a heart catheterization or a nuclear stress test, where you go in for a stress test that has imaging, the radiation is oftentimes double that compared to what a CT scan with a new scanner like we have here is. So it's reduced radiation to the patient, but it is for low to intermediate risk patients who don't have a known history of coronary disease, but who may be having symptoms that could be from coronary disease. And so we can also assess how much calcium is there, but also a lot more characteristics of plaques within the arteries.
That's a great answer, is that there is some concern about radiation and how much radiation we get. There's a question that says, what types of tests might be used to determine if a stent is doing their job? There's a fair number of those. Go ahead, Casey.
Yeah. So I would say that, there are several different tests, and it kind of depends what we're looking for. If we think there's a high risk that the patient is having significant emergent symptoms because a stent has closed down in a fairly acute setting or suddenly, that's going to be a heart catheterization. That's still the gold standard test to look for a stent being open within the artery. And that's because the doctors who do those procedures, the interventionalists, are going in with a catheter and a wire. And if that stent is closed up, they're able to intervene and fix that. Now, a patient who's not having emergent symptoms, but is maybe having some increased shortness of breath or chest discomfort over time, over weeks and months, we can do CT scan to look for stent patency or for a stent being open. But again, that would be in a patient who's not considered to be in a high risk situation right now. And then last but not least, we do MRI to look for scarring in the heart. So if there's been a patient who's had a history of stents, but now their heart is not functioning well, and we're worried there's a lot of scar tissue there, we can do MRI to look for the amount of scar tissue that could have been caused by a stent closing down over time.
That's a good answer. What does a cardiac stress test actually measure? That was one of the questions.
Good question.
It depends on the stress test too.
Yeah, there are lots of types of stress tests, but I think at their base, most of the stress tests are trying to give some sort of measure of what the perfusion or how much blood flow there is going to the heart and all segments of the heart when the heart is under stress. So on a treadmill test, you are physically working to increase your heart rate and make the heart work harder. And we're monitoring either EKG or using an ultrasound of the heart to make sure the heart is still functioning normally under stress. Again, that's just a marker of whether there's a blockage limiting blood flow. So if we see changes on an EKG during exercise or changes on an echocardiogram where a piece of the heart muscle doesn't move well, that is a marker that there may be a lesion or a blockage in the artery that limits blood flow, limits perfusion. Similarly, for those stress tests where you go in and have a medication injected and you lay inside a scanner called the nuclear stress tests, those are markers of there being limited blood flow. We're doing imaging modalities to look for certain areas of the heart that don't get the same amount of blood flow as others. And so that is all different compared to heart catheterization and CT scan, where we're physically viewing the arteries and looking at those blockages directly, compared to doing a stress test where we're testing how well the heart functions and looking for markers that there may be limited blood flow from a blockage.
That's a great answer. And I'm going to pass on to Matt because this is one that's going to take you a minute. So what are the medications you can use for atrial fib? And is rhythm, does it matter if you stay in atrial fib or you get back in normal rhythm?
All right, so that's yeah.
Remembering that.
Ready for another talk? Yeah.
Yeah, I know. But that's a good. I mean, the rhythm question is a good one, I think.
Yeah, no, that's a good. It's a good question. So about whether it's okay to stay in atrial fibrillation, the short answer is I still follow kind of three rules. If you don't have heart failure, if your heart rate is not out of control, and if you're not symptomatic, or if you can tolerate how you feel, then I don't feel obliged to put someone back into normal rhythm or to work hard to keep them in normal rhythm. There is some suggestion, there's sort of emerging evidence that maybe early on in someone's diagnosis, there might be some benefit to putting them back in normal rhythm, but I have some questions about those studies. So I still follow those rules I just explained to you. Now, if we are trying to put someone in normal rhythm, I showed you that picture with about half a dozen medications that can be used to try and help people in normal rhythm. And let's see. So there are a number of them. There are certain circumstances under which medications, can be better for a patient or not. So some people with heart disease, more advanced heart disease like heart failure or a history of heart attack, there are certain medications that should be avoided, but there are other medications that can be utilized. In the end, it's a trade-off of what are the potential side effects of the medications, what are the risks of taking a medication versus what's the potential benefit, of and the ability of that medication to help keep someone in normal rhythm, without going on and on about
Yeah.
about each of them. Yeah.
No, I totally agree. And I think if you're not bothered by the atrial fibrillation, you don't have other things going on, and you remain anticoagulated, that you should be able to go about life as normal, even
That's
though you're
right.
not in the normal rhythm.
That's right. Yeah. And you probably do this, and I occasionally find that, it's, I'm reassuring patients. They say, oh, it's okay for me to have atrial fibrillation, reassuring them that as long as they're addressing any outstanding risk factors, and as long as they're addressing their stroke risk, if they feel all right, yeah, it can be a just fine way to be. Yeah.
There's a question that I'm going to answer, and then I'll say, it says, what is heart failure? And is that the same as congestive heart failure? And our next session will cover some of that, but congestive heart failure is the big topic. And then underneath congestive heart failure is different types of heart failure, be it systolic, where the heart doesn't pump as well, or diastolic, where it's too stiff or big as opposed to small. But I think Dr. Rose Jones will get into some of that in the next session. Any other questions or anything you guys would like to say?
Well, it looks like a question popped up on the chat,
Okay.
Paula, about.
Oh, there you go. I didn't see that one yet. Go ahead.
It says, when would you think that shortness of breath is more related to the heart than the lungs? And that's a good question. That's
not an easy one to answer.
Not an easy one to answer. But yes, that's.
It is one that I think could be answered somewhat if you were in the clinic with the physician and that we do our test called pro-BNP that is normal, then we sort of more shift toward the pulmonary issues, I think, because if you have heart failure, your pro-BNP is not going to be normal, most likely.
Yeah, I think, right. Like, I think it's fair to say that there are a number of different contextual factors we would take into account to try and help sort that out. I think it's not. Yeah.
And if your weight's normal and you don't, if you look like your volume is normal, then unlikely to be short of breath from heart failure. A lot of people that get short of breath and come in thinking they have heart failure really are just deconditioned. Exercise over the last year for sure has gotten people haven't been as good as they've been in the past. And it doesn't take very long to get deconditioned. It takes a long time to get conditioned. If you're in bed for 2 weeks, you lose half of your conditioning just by having an illness for 2 weeks. Well, thank you guys very much. Brian, are you there?
I am here. Yes, thank you, Dr. Baker and Dr. Gazda, for these great presentations. Really, a lot of great information on a subject, honestly, that many of our, I think, attendees probably didn't know a whole lot about, but they're interested. So thank you so much for those really good overviews. I'm sure that they will spur further questions and inquiries to Dr. Miller and maybe you direct. Yeah,
we'll put them right on the mat in Casey's clinic.
That's right. But thank you all, everyone who had joined us today. My name is Brian Freyking. I'm Director of Development for the UNC Health Foundation, and I work directly with the Division of Cardiology and Dr. Miller, as well as many of the physicians that we have seen over the last 2 days. This has been a great symposium. It's 2 quick days. I can't believe the last session is in about an hour from now. So that's a nice little reminder. Dr. Miller mentioned this, but at 2:30, we'll have our final session on heart failure and management of heart failure. So please, if you have not signed up for that and you're interested in learning more, you heard about quite a bit of it in this session. So tune in, and I'm sure you'll be enlightened and learn a lot more about heart failure. But I did want to, number one, thank Dr. Miller for just her continuing work and dedication to women's heart health and to pushing this symposium so that it can be successful. We were really appreciative to be able to be included and to help with this year. And I do want to make point to say, on top of what Dr. Miller said earlier, that this is a symposium that the intention from the beginning was to make it accessible and to anyone who's interested in coming on and learning more about heart disease, especially on the focus for women. And we've been successful in doing that. And some of that has been due to private generous donations. that have been made on behalf of Women's Heart Program. And I'm happy to say that that this continues. And if you'd like to learn more about the Women's Heart Program in general, or if you'd like to learn how to become engaged and support Dr. Miller's work in the program, please reach out to me on my email and my phone number on the screen, and it will also be shared with the resources that you receive next week in the follow-up email. Last couple things. One is you'll be getting a survey right after the Zoom meeting ends. It's very brief. It'll take about 1 or 2 minutes. If you please take that time to let us know what you thought. And also, if you have any other ideas for the future for cardiology or any other area that you're interested in. We've done about 75 of these events over the last 12 months. So we've got a lot of great information out there, but I know there's always questions on our healthcare that we can do a better job of putting out the information and educating our community. And Dr. Miller, you have any last thoughts before we sign off?
Just thanks to you and Allison. We couldn't do this without the Medical Foundation and all of the wonderful help you've given us in getting it together, because it could easily have just gone by the wayside in this year of COVID, but we didn't. So we haven't skipped a year in a while. So I look forward to working for next year. And maybe, as Allison said, we can make it a hybrid, in person and Zoom, both available.
Definitely.
No, thanks to all of you, and to Matt and Casey for sure for taking the time on a Friday afternoon to share your expertise.
Exactly.
Especially Casey, who only had 3 hours sleep since she was on call last night.
All-star.
Yeah. So I will, the next session starts at 2:30. I'll see you guys around 2:15.
Thank you, everyone.
Thanks.
Have a great afternoon.
Thanks a lot.
Bye.